I hope it will be useful for you. So my name is Assel Terlikbayeva, and I'm Director of the Global Health Research Center of Central Asia. And today I will share with you information about evolving health challenges in Kazakhstan and Central Asia and syndemic conditions, and how we address them through research and innovation. So Kazakhstan is the 9th largest country in the world by its territory, with the capital in Astana. Biggest city is Almaty, which is my homeland city. Kazakhstan was a place of deportation for many ethnicities in Soviet Union times, so it's a home for more than 100 different ethnicities. And official languages are Kazakh and Russian. Kazakhstan is very rich in oil and natural resources, and has a relatively strong economic influence, and its cultural diversity, history, and strategic location between Europe and Asia deeply share its health systems and challenges. So, as you can see, Kazakhstan's geographical position makes it a regional bridge because it's located between Russia and China and the rest of Central Asia. So, and it makes Kazakhstan a key player in balancing geopolitical, economic, and social forces in the region. So, as Rick mentioned, migration is a major dynamic in Kazakhstan demographics right now, and it's driven by labor needs, also geopolitical instability like war in Ukraine. And as you see from this graph, we not only have migrants from neighboring Central Asia countries, which account mostly for labor needs, but we also have quite a huge population of migrants coming from Russian Federation, starting from 2022 because of the war with Ukraine. And we also have migrants coming because of the different discriminatory policies, especially LGBTQ policies in Russian Federation and neighboring Central Asia countries. So it makes Kazakhstan more welcoming and attractive to this book. Also, Kazakhstan's position is along major drug trafficking routes from Afghanistan to Europe. And of course, this position contributed to rising substance use, HIV transmission, and overdose challenges in Kazakhstan. And these issues that we directly address in our work. And now that we have set the stage geographically and politically, let's move to emerging health challenges that we have. Well, similar to your country and to other countries, we have high burden of non-communicable diseases, of course, cardiovascular diseases, cancer, along with infectious diseases. We still have very high burden of tuberculosis and HIV, and growing mental health concerns. And our research uses a syndemic approach, as Rick mentioned, because we see that such conditions as substance abuse, violence, and HIV/AIDS interact with each other and drive poor health outcomes, particularly among key populations. So this is the syndemic that we address very often in our studies. SAVA is substance abuse, violence, and HIV/AIDS syndemic among women who use drugs and very often engaged in sex work. Among these populations of women, depression increase 15-fold, and suicidal ideation 6-fold. And Kazakhstan faces especially high rates of intimate partner violence. Our studies show high lifetime drug use among people who use drugs, and alarming rates of witnessed and experienced overdose, which underline the need for integrated approaches, integrated interventions for HIV prevention and overdose prevention, which we have done. And LGBTQ communities face compound stigma and barriers to care. And this is the data from our study on increasing HIV testing among MSM and trans population of women of men. It's among 629 MSM baseline, and we were looking at associations between stigma, internalized stigma, and connectedness to sexual and gender minority community, and we are able to show that that there is a negative association between HIV testing and stigma, and positive between testing and connectedness to the community. And this is how we developed our intervention, and we'll later talk about it. Some of you asked me about TB situation in the region. This is one of the directions of our work as well. Kazakhstan has done a lot of work on decreasing TB rates in general population. So it is 45 to 50 among 100,000, which is good. But we do have high rates among migrants, very high rates among migrants, especially MDR TB rates, which is over 80% in some groups. Because sometimes it overlaps with incarceration among those migrants who are incarcerated and also belong to migrant population, the rates are very high. And this is driven, of course, by TB treatment interruptions, screening gaps due to delays in seeking care, and restricted access to care. And although Kazakhstan offers free TB diagnostics and treatment to all residents, including migrants, we still have a lot of barriers, structural barriers. We in the same study that MSM I talked about already, we also looked at minority stress and sex practices and stigma. And this paper is not published yet, it's under review, but we looked at association between minority stressors and psychological distress symptoms, between different forms of victimization and depression, anxiety, and stress. So, and we were able to prove that there is a association, and then this is a study that was published just recently by one of our colleagues from Germany. We worked together with him on chemsex practices among MSM in Kazakhstan, and from qualitative interviews with participants, we were able to see that this was chemsex. They've used chemsex as a way of coping with minority stress and social stigma. And you also asked me about suicide, and of course, this is very sad, but Kazakhstan has the world's highest suicide rates among adolescents. It's the second among boys, and actually first among girls aged 15 to 19. And of course, boys made up 68% of suicides among minor under 18. while girls accounted for 32, but girls are higher among rates of completed suicide. They attempt suicide, but boys tend to complete suicide, and the girls attempt suicide. So, but the underlying reasons for such huge suicide rates are family conflict, bullying, loneliness, academic pressure, and unfortunately lack of mental health support. We don't have interventions, mental health interventions addressing adolescent mental health needs. And this is something that we started to do recently. We are addressing a gap in research on how mental health and cognitive function influence the adherence to ART among aging population of people living with HIV. This is something that is addressed here a lot, as I understand, because I met with people last week and this week, but it's a new topic for us. And our findings suggest that depression, anxiety, and worsened cognitive function were associated with poor ART adherence and lower adherence self-efficacy among a cohort of people living with HIV. So these complex health challenges demand integrated community-centered solutions. And let me share how our center, Global Health Research Center of Central Asia, has been working to address these intersecting health challenges. Our center was built in 2007. It was established by Columbia University with seed funding from the President's Office. And the center bridges science, community, and policy work. We address HIV, TB, mental health, substance use, and violence through integrated community-centered research and interventions. Our research starts with assessment, epi studies, and then we progress with developing interventions, and then we conduct implementation science studies to integrate interventions into routine care. We also do policy engagement. We generate data for national programs and for regional strategies, and we do a lot of capacity building. So we are training through such programs, collaborations with T43 programs like Jack Dehovitz. We were able to train early career researchers, investigators, and we also conduct our own training programs for health workers and NGO organizations. So this was one of our key studies. It's an anchor study for our center, Renaissance. It was an integrated interventions, couple-based intervention to reduce HIV, HCV, and overdose risks among people who inject drugs and their partners. It was a culturally adapted intervention, and now it's evidence-based. So, and with this intervention, we actually were able not only to reduce HIV, HCV risks and overdose risk, but we were able to decrease also substance abuse, which was like a secondary outcome. But maybe because we work so long with this population of people who inject drugs on their self-care and health needs, they started to think about them and reduce their substance use eventually. And this is another study. This is implementation science trial. We called it BRIDGE, on improving service delivery for people who inject drugs. It was conducted in 4 sites across Kazakhstan in 24 syringe service programs. And we implemented a package of 3 interventions. First was social network strategy, the other rapid testing, and linkage to care. We bundled them into one package, adapted to syringe service programs in Kazakhstan, and implemented them through providers. So these nurses, 24 nurses, social workers, outreach workers, aid center supervisors were trained how to use this intervention, and by doing that, they were able to increase attendance rate at syringe service programs, increase HIV testing rates, and linkage to care. So we increased number of people who initiated ART at the aid centers. And I'm happy to say that these interventions were later disseminated and taken over by the government of Kazakhstan. So now they are integrated into HIV centers routine practice. They use social network strategy for their daily outreach programs and case management for linkage to care for their working with people living with HIV.
So could you say a little bit about how the social network strategy worked?
Social network strategy, we worked with outreach workers, and through them we were able to identify some leaders, like peer leaders, among people who use drugs, who recruited other, who were able to teach and or to train other recruiters in the community. And this was like a cascade. So they were training each other and recruiting each other to come to syringe service programs. And this is, of course, our study with Yale University, with Doctors Ricoltis and Lynn Madden. We are working on expanding methadone-assisted therapies in Kazakhstan. So this program has its difficulties, of course. We are facing structural barriers, but we have to say that Kazakhstan has made significantly big progress. Big progress in terms of transitioning the program to the government of Kazakhstan after many years of the program being supported by international organizations like Global Fund. Now, starting last year, it's been owned by the government. The government is procuring methadone for the country, supporting the sites. We do have some issues with supply and distribution of the medication across the country, but the government commitment is there. And we are working with each team across the country. We have 21 sites to coach them on how to overcome these barriers on the ground at each site. So we have our next collaborative meeting very soon in May, and I look forward to that. So we have done a lot of work on LGBTQ communities and trans MSM and trans people. I don't have time to talk about each study, unfortunately, but we have done this. Pride in HIV care was our one, where we focused on building this community connectedness among MSM and training community influencers among them to promote HIV testing. And it was using crowdsourced materials. So it was, this study was done during COVID, and actually had very good results, even though we were not able to recruit the sample that we wanted, but still the results were very powerful. And at the same time, we were fortunate to get funding from Melbourne John Gates Foundation to initiate the online HIV self-testing program. We received the supply of 10,000 tests, HIV tests. And I think together, these two interventions really made a huge community impact because we were able to increase HIV testing among MSM population significantly, even during COVID times when everything was closed. The HIV testing rates among MSM were rising. So, and I think these two studies, they lay the ground for Global Fund funded PrEP scale up in Kazakhstan, which started in 2021. And because the MSM community was already activated, they were aware of PrEP, they were actively testing. I think PrEP, that's why PrEP launch went very well, especially among the MSM communities. The government decided to scale the program across the country immediately. So it started everywhere. And just in 3 years, we have more than 6,000 clients on PrEP. We provided technical assistance to the government working on MSM and using all our tools that we developed so far. And so as you can see, this coverage of key populations increased year by year. It's still not enough because the target is, I think, for 2026 is to reach 15% of key populations. So we have a lot of work to do, but the progress has been good so far.
What is the FO, the number FO27 above NGO 9?
Oh, I think it's a translation 27 sites. Yeah.
So the FO is.
But facilities, I think.
Oh, okay.
Yeah.
Those would typically be healthcare facilities.
Okay.
Yeah. So yeah, and again, this is we conducted several studies on women experiencing SAVA syndemic. Yeah, and each of these studies they deserve a special talk because these are big studies. But yeah, if I can briefly describe, we worked on individual level by increasing women economic opportunities. Like NOVA was focused on building women economic opportunities and vocational training so that they can take care of themselves, take care of their health. And the GIDA was on addressing self-stigma and also about how to take care of yourself. And while addressing self-stigma, we use some CBT components like cognitive restructuring. And it worked actually very well because by doing that, we were able actually to increase HIV testing rates among these women. UMAI WINS, it's intimate partner violence reduction intervention. It's a digital intervention. It worked not only on individual level because we worked with women, but also on community level because we were able to engage communities to address structural barriers in accessing government services for women. And WLEO is an intervention working on stigma among medical providers towards this population of women. And just briefly, because we talked about youth, we have done this digital intervention addressing primary substance use risks among among school children using family-based approaches. So we formed diets of adolescents and their trusted caregivers. And through these interventions, we were able to develop bonding connection between them, so that this connection and trust prevent them from stepping into vulnerable situations and like peer pressure to use drugs, binge drinking, and so on. And this is another study we conducted among youth to reduce HIV stigma among youth towards HIV testing. And it was a crowdsourced intervention developed by youth themselves. So through this project, we were able to take to learn some lessons, and I think the biggest lesson that we learn is that we always need to work with community through all stages of our research. We need to address structural barriers and social determinants of health in our research. And we need to build sustainable cross-sectoral collaborations with the government, NGOs, and academia. And of course, we need to invest in capacity building and sustainability. And moving forward, we aim to expand digital mental health interventions, integrate services for co-occurring conditions like HIV and NCDs, and focus on regional collaboration, workforce development, and evidence-informed policies. So acknowledgements, and first of all, I have to say that I won't be able to do anything without my team, because it's not just me, of course. We have a great team of dedicated young professionals. Some of them were also educated here in the US through some of the D43 programs. And this is my family. And of course, my big thanks goes to our sponsors, partners, investigators, communities who trusted us and worked with us through all these years. Thank you, and I look forward to your questions and discussion. And just this is our office, some contact information, and this is just some photos from Kazakhstan. You're always welcome to visit us if you like. Yes, and we will be happy to see you.
Thank you so much, Assel, for the lovely photos and for the really inspiring talk. It's incredible what you've accomplished in so many different areas. I think what we'll do now is open it up to the room and also to the online for some questions to hear more about what you're doing. Maybe I'll start just with one question. I really liked how you had the slide that had sort of the 4 areas, research, capacity building, implementation, then of course, policy and advocacy. And I wanted to ask you a little bit about that last piece, particularly as it relates to digital health, because you've done a lot of digital health interventions. I know there's a lot of interest in that in the room. It's actually something that CIRA, in its most recent grant, is really trying to kind of expand our capacity. And it's such a rapid moving field. I know that often people struggle to keep up with the technology. How have you guys approached that in terms of your research and your partnership with the government? Do you get much regulation from the government in these areas, or is it a very free environment to develop things? And what strategies have worked really well for you when it comes to your success with mental health interventions or digital health interventions?
Well, from our previous work, digital world was not so much controlled and centralized. when we did our study with youth, for example. So and it was a multimedia intervention. So it was it didn't collect any data. We were just showing some pictures and uh, and that's it. But now we're thinking about digital interventions for PrEP, for example, and of course we are faced with issues like electronic health records and confidentiality of personal medical data, and and this field is very much regulated in Kazakhstan. Yes, so we do have challenges. I know that our partners also had challenges with using different applications, because only limited information can be uploaded or shared within the app. So I think some legal work has been done, has to be done. First, some consultations with lawyers have to be done, before we start doing some more advanced work. But Kazakhstan has all the capacities because we do have very huge centralized databases of all medical records. But Roman was trying to get some of this information, and but we have very good working relationships with the government, and it just takes time and negotiation.
Thank you.
Yeah.
Sheila?
No, nothing on Zoom.
Thank you for a fantastic presentation. Really, as Luke said, it's a remarkable body of work. And it seems like you've been very successful with the implementation studies and having the government kind of take over. I think particularly the Pride and Bridge and maybe XMAT, right? Which is phenomenal. And I'm curious more about what that looked like. Was there did the government adopt the protocol that you had evaluated? Did they adopt it wholly, 100%? Was there some adaptation of that process that they, there's always resource limitations that affect, adoption. I'm wondering about, was there, or is there an opportunity in the future to kind of evaluate that dissemination process, and how well has the government put those protocols into practice? How well are they doing with that intervention?
Thank you for this question. Yes, it's actually with the Bridge study, we have thought a lot about doing another study on looking at how the government implemented the components of intervention. We had a package of 3 different interventions, and frankly saying, it was very expensive package, right? Because we had the NIH funding to implement it in controlled environment. It was a research study, and we had resources, but for the real world, we really had to adapt the intervention, and we didn't really transfer the whole package. So we discussed with the government what would be feasible for you to take, and they said that the social network strategy looks feasible to us and can be can be done in the real world, and some elements of case management. So, and we gave them a lot of information, and they picked something that they can really implement. But yeah, we don't have, we thought that we can apply maybe to NIH to get funding for evaluation how this implementation is going, but we couldn't find funds.
Assel, could you talk a little bit about your training programs? You talked about your collaboration with Jack Dehovitz, and then you also mentioned that you guys do a lot of training directly. How you structured those programs for the people that you're trying to train?
So So yeah, we do have a long time collaboration with Jackie Horvitz, and this program I think is running in Kazakhstan for more than 10 years. And through this program, we trained many of our staff. They got their masters in epidemiology, masters in public health in Pomodi School of Public Health. And then they came back and rejoined our center. And now we have the core team of really good professionals with good education and epidemiological skills, biostatistics skills. And actually, Jack even proceeded with building the whole department of epidemiology at local medical university. And one of my colleagues trained by Jack now is head of the department of epidemiology at medical school. And she now trains the new generation of students through the university. And we through our projects, we train the community. I told you about the community engagement that we do in all of our studies. So because we hire people from the community, and then we train them in research ethics, how to do qualitative research, how to run focus group, because we won't be able to do this kind of work ourselves. We don't have, I mean, we need to have access to community, and we need people whom the community can trust. So we train them and educate them on how to do some basic research communities.
Wonderful.
Mhm.
Chenlin.
Thanks for the presentation. I have so many questions. The first is, when we talk about global health, I think a lot of times people are looking at the region, right? Like in this case, people, or if you're looking at papers or whatever, people talk about Eastern Europe, Central Asia. But I think each country is very unique in terms of its culture, its society. What do you think, when it comes to all the challenges that you mentioned and health disparity that is so unique of Kazakhstan compared to some other countries in that region?
In Central Asia.
Yeah, so that's the first question. And the second is, so I saw that in the implementation science trial study, you involved social worker. So I'm a social work scholar, and I see a lot of familiar names from Columbia as well. I wonder what social work as a professional is functioning in Kazakhstan, both in terms of HIV prevention, in terms of mental health promotion. Yeah, because I have no idea, social work. I'm from China. Social work there is completely different than what social worker, does here. So I just wonder, what typical, rules or their responsibility, or in terms of their, the way they contribute to your work in the specific setting.
Thank you. Thank you. So your first question is, what is unique about Kazakhstan?
Right.
So, well, as I told you, Kazakhstan is its geographical position is between Russia, China, and other Central Asian countries, and the migration trends. We have all the migrants from Central Asia, migrants from Uzbekistan, Kyrgyzstan, Tajikistan are coming to Kazakhstan. So you actually can do studies among Uzbek migrants, Kyrgyz migrants, Tajik migrants not living Kazakhstan. So we have done it. And now with migrants from Russian Federation, we can also do studies on them. And it creates totally different dynamic in the country, because we have so many influences and driving sources. Well, it's also that Kazakhstan has more economic opportunities, and that's why Kazakhstan is more independent from international forces. That's why Kazakhstan can take some of the interventions that were proposed by us. Comparing to neighboring Kyrgyzstan, Tajikistan, they just don't have funds to support these programs. And this makes our work more sustainable in Kazakhstan, because we can form these working conditions, and we can trust that the government will pick up.
Mhm.
And then about social work, well, I don't know if you know, but in addition to my medical background and MPH, I also have MS
Oh,
from Columbia School of Social Work. Yes, and we have done some big amount of work on social work development in Kazakhstan, especially on integration of social work into healthcare. We trained primary healthcare doctors on how to work with social workers, and some graduates of social work school. We had few schools of social work, how to work on such issues as HIV, mental health, substance use, what is it, stigma, and we have done many trainings.
awesome, fascinating. Thank you.
So there's a question on Zoom from Jeremy Schwartz. So truly fantastic and eye-opening presentation. Can you talk about how using a syndemic approach has specifically shaped your work and your intervention development?
Yeah, well, it shaped a lot. I think it shaped the whole concept of the Global Health Research Center of Central Asia, because we see each program as integration of different dynamics. We work in intersection of substance use, HIV, mental health, overdose, gender-based violence, and we try to include all these components into our interventions. Our interventions do not address just one issues. They address many different issues. And so we're trying to fix many different things at the same time.
I guess, thank you, Assel, for the presentation. I guess as a follow-up question to that, I was wondering if you could speak a little about how the health system is structured in Kazakhstan, because I know you have like narcology centers, you have like AIDS centers, and how that system fragmentation has kind of like challenged that syndemic approach.
Yeah, we do have a very vertical system. It's inherited from Soviet Union times. But recently, Kazakhstan has turned to developing primary care, and actually it started even earlier. Maybe you all heard about Almata Declaration of Primary Care. This is something taught in public health schools. Yes, so this declaration on primary care and universal access to healthcare was first signed in Almaty, Kazakhstan, and and it took Kazakhstan, of course, several decades to move closer to universal access to care. But now I think we are almost there, because we have reformed our healthcare so that we focus a lot on primary care. We try to integrate services there. So mental health services are actually now integrated in primary health, in primary care. TB care integrated, some substance abuse services are integrated. So so many things can be done. Post primary care is overloaded. Yeah, it's a lot of burden on them, but we try to think about other directions. Now we are trying to think how we can integrate other conditions into substance use programs, for example. Now we're developing a new program for PrEP integration into substance use programs, HCV testing in care into substance use programs. So we work in both directions. Primary care, like a integration there, and in specialized services.
So could you say a little bit more about the challenge of working with migrants? You highlighted that as really important to the local economy and driving maybe a lot of the kind of risk factors in the populations that you're studying. But if those populations, I guess, leave and go back to where they came from, how does that pose a challenge for you in terms of your research, but also in terms of kind of understanding the implementation of your program? How do you guys deal with that?
Well, for with migrant population, of course, it's difficult to work because of their mobility. It's really hard to have any longitudinal studies with migrants because you never know where they will be next month. They're collecting their contact information was difficult. But we had few studies on migrants, and they face a lot of challenges, not only HIV, TB, but also alcohol abuse, mental health issues. We saw high depression rates among migrants. And we had difficulties linking them to care because many of them lived with undocumented status. And although services are free in Kazakhstan, without documentation, it was hard to link them. Yeah, so we screened them for HIV, HCV, TB, but then we had difficulty linking them. So that was the main challenge, and it required like regional work, some inter-country negotiations, and we were trying to enter these dialogues, but they were out of our control because on a very high level, regional level discussions, and we were trying to partner with other organizations directly working on these issues, like IOM, Organization for Migration, because this was out of our mandate to negotiate these kind of things. So yeah, the biggest challenge was linkage to care.
Thank you.
And to sell that linkage to care, is it limited by the idea that they have to have a propiska to be legally within an institution to get healthcare? Or will they provide the healthcare even though they're not a citizen, but yet there are other sort of constraints on that?
Well, Kazakhstan has universal care for all residents for HIV and TB, and can provide some diagnostics and some treatment, but not long term for TB, for HIV. So I think the biggest challenge was this long-term care.
Well, I think we have one more question.
Kind of building off of those questions, I was curious about, it seemed like a lot of interventions were a little bit more targeted to some of the cities, how you've kind of recommended to the government then how to really apply that to more rural care, and if you've seen like challenges or successes with that, if you've done any more studies that are a little more centered for rural care, just like the largeness of the country and how you've kind of overcome that.
Yeah, I understand that, but sorry. Yeah, working with rural communities is of course very important, but because our work is mostly with key populations, it was just very hard to identify these key populations in rural areas and recruit them for the studies. We couldn't just sample these populations, and that's why it was really difficult to do. And well, in some of our programming, because we do programs with Global Fund, we develop online services. And this could address this rural area needs.
Well, I'd like to thank everyone for coming today and give a special thank you to Assel for this amazing work. Let's give her a round of applause. I would encourage everyone to follow up afterwards if you have additional questions. Thank you for being here. For those who are online, there'll be a short survey afterwards. We always welcome your suggestions about CIRA international programming, and those that are here, there's no specific survey, but please let us know if you have suggestions or ideas of topics that you want to cover. We touched on a lot of things today that fit within the CIRA mission: international research, digital health, migration and health. So it'd be great to engage with Assel and others in the future. So once again, thank you again, and thanks to Rick as well.